Members, this is a special meeting of the panel on health services. We have a quorum. Please raise your hands if you would like to ask questions. The secretary has just finished the meeting next door. Let's give him some time to prepare for this meeting. If you do not object, I believe that a lot of members would like to ask questions, and this meeting is scheduled to finish at 6:30. Perhaps when the secretary is seated, I will dispense with a presentation of the paper because members probably have read papers. I believe a lot of members would like to ask questions, and we will start with 5 minutes per member. Let's invite the administration to join us. When the secretary is seated, we can start.
There
are some housekeeping matters. Today's meeting is mainly about the consultation documents. You may be interested in either or both of the consultation documents. We'll have a chance to discuss the individual consultation documents. There are two parts: Voluntary Health Insurance Scheme and Regulation of Private Healthcare Facilities. We do not have a subcommittee. We do have a subcommittee. Perhaps if you want to have a detailed discussion of Voluntary Health Insurance Scheme, it would be better for discussion to take place in the subcommittee. Whereas for the regulation of private healthcare facilities, perhaps we will have a discussion in the panel instead of having discussions of the two items together, because it will be confusing. Just a point of order. Both documents are equally important, and the public are very concerned about both. Would you consider organizing public hearings on the two documents to hear their views? This is something we have to discuss about. There are two parts in the consultation document. And there may be confusion because people may not know what actually we're talking about, the health insurance scheme or the private healthcare facilities. If you think you need more time on the voluntary health insurance scheme, perhaps the discussion will continue in the subcommittee, and the subcommittee will conduct a public hearing. For the HSP, we will focus on the regulation of private healthcare facilities and the public hearing so that we can separate the two to make it clear. If we have one single public hearing, it may be very confusing. If you agree, I will arrange with the clerk. Well, I know that the secretary is very busy. He's dealing with vegetables and chicken next door. Well, unless you would like to say something, we can dispense with the presentation of the documents by you, secretary. Let's have 5 minutes to start with. Only one round. If you would like to ask questions or speak, please raise your hands. We have Wong Kok King, Alice Mack, KK Kwok, Pun Siu Ping, and Fernando Zhang. Mr. Wong Kok King. Thank you. In relation to the health insurance scheme, VHIS, of course, we need to have a long time to deliberate and consider it. The most important thing, the way I see, is whether it's attractive enough. And it hinges on two things. First, tax concession. If there is sufficient appeal from the side of tax concession, members of the public would like to participate. And in this way, the burden on the government will be lessened. So it's a win-win situation. So when it comes to tax concession, I think there are some numbers mentioned in the document, but I don't find that very attractive. Will you consider increasing the tax concession? People who take out policies may enjoy a full tax concession on the amount, on the premium. And in relation to the scope of protection, especially when it comes to critical illnesses, if it's just a minor ailment, it doesn't really matter. But when it comes to serious illness, when you really need the policy protection, very often you're told that a lot of things are not covered. With the VHIS, will the protection cover be more adequate? First of all, when it comes to attractiveness, we need to look at two things. If you look at incentive alone, maybe some people will find this not attractive enough. But of course, for consumers, they will look at quality first. There are a lot of people who would like to take out an insurance policy, but they're unable to do so. And even if they succeed to take one out, and if they make a claim, it will be difficult for them to have a renewal of the policy. And currently, the scope of coverage would need to be increased. So when it comes to an enhancement in quality and whether sufficient protection coverage is given, that itself is a factor. Of course, financial incentive is another. We propose a financial incentive in the form of tax allowance for people who don't have to pay tax. Of course, they won't find that attractive. And for people who have been working for some time, and if they have to pay tax, say 8% of their income, then the tax concession will be attractive to them, because it will help, say, by about 8 to 10%. The second part of your question, critical illness and what are excluded. For some existing policies, pre-existing conditions may not be covered. And under our proposal, these conditions will have to be covered. Of course, it will have to be done by phases. Maybe they are not covered in the first year, and then as time goes by, say the second or the third year, a certain percentage of the pre-existing condition will be covered until all the pre-existing conditions are covered. So can we have the entire premium tax deductible? Can you maybe increase the appeal? Will you consider it? I think we're talking about tax deductions. If the premium is not over the amount of tax deductions, then then it is a tax deductible. If you're talking about getting the government to pay for people to take out policies, well, we've actually heard views saying that they don't want the government to use direct financial subsidy to support a business operation. Ms. Alice Mack. Well, I would like to ask about the regulation of private healthcare facilities. The government said that now there will be a two-tier complaint mechanism. There will be an independent complaint handling committee for private healthcare facilities. What is the power of this committee, and how much can the Academy of Medicine be involved. And in relation to ambulatory centers, there is no independent committee to regulate these ambulatory centers. Well, if the VHIS cover ambulatory procedures, we can foresee that ambulatory centers will handle more and more of these ambulatory procedures, and then there will be more complaints. If there is confidence given to the public, then they would be willing to go to the private sector. So there should be a sound complaint mechanism so that members of the public can lodge a complaint when something happens. So I think that when it comes to ambulatory centers, there should be a similar committee like the Independent Committee on Complaints Against Private Hospitals. My third point. There is little regulation of the private healthcare sector. I don't know how much the premium will be in the future. The government said it's going to be 3,000. But perhaps with insurance, private hospitals will keep increasing their fees or the charges in the ward, and as a result, premium will increase. What about service? You ask them to give transparency and to quote of the fees. Well, what about the ratio of the different classes of wards? A lot of people say that they're told in private hospitals that there is no general ward and they have to pay extra to stay in a private ward. Are there any regulations to keep the fees in control so that they will not wantonly increase the fees? When it comes to complaints handling, under the existing legislation, there is no clear provisions requiring private hospitals to handle complaints. In the future, we will require private hospitals to set up within the hospital a complaint handling mechanism. That is different from the current practice. There may be a similar body in hospitals, but there is the hospital's own initiative in setting these up. And in the future, they will be required to set this mechanism up, and this will serve as the first tier of the complaint handling mechanism. And in the future, power will be given to the committee to set up the second tier. We won't ask clinics to set up such a complaint mechanism because it's small in scale. We can't ask them to set up a mechanism like the one in hospitals. When it comes to charges, well, it's because of the reason you mentioned that we propose this regulatory regime in order to ensure that private hospitals will put in place a transparency, enhanced transparency when it comes to the fees charged.
They have to publish the records of charges so that people know, and also on the quotation. Now, of course, it's a selective procedure, then they have to follow the quotation list unless it's an emergency. Now, thirdly, there are insufficient beds right now, so the problem has risen. Now, in the future, with voluntary health insurance and with regulation of private healthcare facilities, then round about 2020, the private hospital beds will increase by 30 to 40%. Dr. Kwokaki? Now, healthcare resources are very precious, and we are concerned about that. Now, on insurance, Now, no one would object to purchase of insurance cover, but if one uses public funds to persuade people to purchase cover, now that would be rather strange. Now, the government document says, now why do we have to develop VHIS? It said that given the rapid escalation in cost and rapid population aging, now 80% of the public hospitals patients are over 65, and it's $8,600 per year. If there's long-term illness, if it's a high risk, then it would be double that. So for those 65, we are talking about paying $26,400 for these people to be in the high-risk pool. And also the rise in medical costs. We know that the big spenders are the hospitals. The entire world is trying to engage in preventive medicine. Now, voluntary health insurance asks people to go to hospitals for help and not to engage in preventive primary care. Now, for those who are over 65 and retired, how many of them would pay $26,000 to be in this high-risk pool? It's the rich people. Now, with so much ado, the document says that 3% more people would buy insurance cover. It said that the insurance companies don't earn enough. They make 30% administrative fees. Now, if we have $10, if we $33.60 would go to the insurance companies to cover administrative fees. Now, that's very unreasonable. The elderly people are suffering. Now, people have to pay $80,000 or $10,000 to have a heart procedure. Now here we're talking about $30,000, $40,000 or $100,000 per month. So the amount will be used up in 2 months. Now the government maybe has in mind a scheme to use VHIS to force people to engage private healthcare providers. In that case, I'm sorry, you are using public money. A tax deduction also involves public money. The high-risk pool is to safeguard the interests of the very rich people so that when they retire, they can pay $2,000 per month to pay the premium. How many of the grassroots people can afford that? You say regulation. What do you regulate? You don't regulate the fees, the administrative fees, the charges. Now, they provide a bill. Now, you say people don't use enough of their facilities, so you want people to patronize the private hospitals. No insurance companies would lose money. Now, you say people should use private healthcare facilities instead of public hospitals. In that case, the premium will rise further. I'd like to ask the Secretary, what are you thinking of? Maybe in the long term, the government wants people to drop out of public hospitals and try to patronize, get them to patronize private facilities. Now, when conceptualizing the VHIS, we made it clear this is not a wholesale reform of healthcare financing. Now, what are we doing? Firstly, a lot of people in the public depend on heavy government subsidy of the public healthcare services network. Now, of course, the government is expanding the public hospital network. We will continue to shoulder the commitment to the long-term development of public hospitals. But at the same time, the population is aging very quickly. Chairman, the Secretary hasn't answered my question. Is it trying to force people out of public hospitals? Please be succinct. Otherwise, it will be the second round. Answer right now, please. You have broken up my answer. Please do not argue. The Secretary can choose how he would answer. Can you answer in 2 seconds? I can't do it in 2 seconds. I will explain if I have the time and opportunity. Perhaps next round. Now, the consultation document on page 20, paragraph 45, it says that by 2040, the share of the private sector would increase by over 30%, whereas the private sector, public sector, would shrink by 4%. Now, how can you assure people that the government would not shrink its commitment to the public sector healthcare? And also on VHIS, in the first year, everybody would be accepted, and in the second year, only people under 40 would be accepted. So there's only 1 year. Is it enough time? Would the government consider a longer period, 20 or 30 years, 2 or 3 years, so that people can understand the scheme? Now, using 2012 prices, the standard plan, the premium would cost $3,600. Now, actually, for the high risk pool, it would go up to $10,000. It's now 2015 already. Have you assessed what's the price in current dollars? Now, let me reiterate that in the scheme, the government is holding on to its commitment that for the public healthcare system, the government will continue to maintain its commitment there too. And as I said, it works by many ways to show that we have a plan for the long-term development of the public hospitals. Now, the main purpose of the plan is that some people in the middle class, I reiterate, now for those in the grassroots, if we debate whether they can afford the premium, I don't think that's our objective, because we accept that the grassroots, and we understand that they will continue to rely on the public healthcare system. That is why we continue to maintain our commitment to the long-term development of public hospitals. However, despite the continued investment in public healthcare system, if we have only that one system, then the patients would still suffer, because whether people are rich or poor, they would all pile into the public hospital. So the grassroots people would have to wait a long time for services in public hospitals. For those with resources, they have a choice. Now, even if we don't launch the VHIS, they can still choose to patronize private providers. So we are trying to divert some people to the private providers so that the middle class can benefit from the scheme, but also the grassroots will benefit. Why is there a 40-year age threshold? Here we are only talking about the high-risk pool only. For the other members of the public, now if they are not of the threefold premium loading group, that is the high risk group. Now, because we need a mechanism to absorb those who are high risk. So this is the mechanism so that the insurance companies will provide the cover. Now, we need to look at the figures all the time to see, but we use a benchmark. Now, even if we pass the bill, by the time the bill is passed, the figures would be different anyway. Now, it's 2015 now. Can you provide some figure? Now, we need to check that. Fernando Cheung, Hong Kong price itself on the public healthcare system. We have inherited the colonial system where the healthcare system is provided by the government. So the cost is low to the public, whereas the quality is high. So overall, our healthcare services are efficient and cost-effective in terms of quality, so we can be proud of our public healthcare system. This is because our medical staff are very conscientious and in trying to provide quality service. Now, overall, our medical expense is about 50% on from private sources, that is the patient pays, and the other half is paid by public funds. Now, you can't say this is out of balance. Now, in advanced economies, now for our percentage of about 50% of people purchasing medical service with their own money. Now, that is not a low percentage. That is, in fact, quite high. Now, in many places, most hospitals are public hospitals. Now, you are trying to cut out part of the public hospital system and give it to the private market through the scheme. Now, for private healthcare, the unit cost is bound to be higher than that of public healthcare. So if we pay public money to get the people to patronize the private sector, of course you would raise the cost.
These are the two challenges you mentioned in the document. First is the aging population and medical inflation. And what you propose is actually contrary to possible solutions of these challenges. In the U.S., it was chaotic because the public sector is very weak. And as a result, it's not very effective. In the U.S., the medical cost is the highest in the world. But voluntary health insurance in the U.S. will be an effective means, but not here, because we're simply following a bad example. And in the end, it would be like what Dr. Kwok said. For those who have the money, then the public funds help them. And the fact is that medical costs will be pushed up and the grassroots will not really benefit. We're very concerned whether you have actually gone down the wrong path. Why don't you use the resources to improve public healthcare system so that waiting time will be shorter, to increase manpower, or to put resources into preventative measures to improve public health. Don't imagine that the market will solve the problem of future financial commitment for us. Dr. Fernando Zhang asked if we have carved out some of the public market to the private ones. On the face of it, it seems like we have given resources from the public to the private market. That is not the case. We would like to divert some patients from the public sector to the private sector, especially those of middle class. We do not subsidize people in the use of healthcare facilities in the private sector. We just give them the chance. If you ask your middle class friends, they would like to be able to take out a quality insurance policy, and they can actually make use of it and choose to use more private services. Because in some case, they can choose the hospital, they can choose the doctor, or they can shorten the waiting time. And in this way, we can divert some patients away from the public sector so that the public sector will be able to focus on providing services to the grassroots. I've been in constant liaison with medical practitioners in the public sector, and they would like to be able to do so. And for some people that I've spoken to, if they have to make out-of-pocket payment, they would rather go to the public hospital. And if there is some help, they will go to the private sector. And these people will be diverted away from the public sector. And then the grassroots will be able to receive better services and a shorter waiting time in the public sector. I would like to talk about regulation of private healthcare facilities. And of course, regulation is better than nothing. With the VHIS, some patients will be diverted from the public sector to the private sector. Not all, though. I'm worried that with the implementation of the VHIS, the share of private sector will increase by 36%. And the private sector will be affected, and the main impact will be on manpower. It will be drained. Specialists or experienced doctors, nurses or allied healthcare professionals will be poached by the private sector with a high salary. And now it's difficult to retain experienced and top-notch doctors in the public sector because of the long working hours. So what do you have up your sleeves? That in the expansion of the private healthcare sector, it won't cause a shortage in manpower in the public sector. It's about the entire idea behind the proposal. It's about a proper use of surplus capacity in the private sector. You can ask doctors working in the private sector. They are busy, but compared to their counterparts in the public sector, they have capacity to take in more patients. I won't ask all patients to leave the public market, but I've often heard from my friends in the private sector that there is surplus capacity to take up more patients. So there won't be an immediate drain of manpower from the public sector because they can make use of the extra capacity. I don't want you to have the wrong idea that is a high percentage. The percentage seems to be high because the scale of hospitals in the private sector is small. So a small number of patients going from the public to the market will result in a huge increase in percentage. Of course, we have to ensure sufficient manpower in both private and public sectors. We will conduct a survey to put in place supporting facilities. so that in about 2020, if the proposals are implemented, there will be expansion in the capacity of hospitals in the private sector, and there will also be a corresponding increase in the number of healthcare professionals. In relation to the regulation, I'm concerned about Chapter 5, the governance. You only said that a person in charge is to be appointed, but you did not set out the qualification for the person to become a person in charge. Can someone who doesn't know anything about the operation of a private hospital be the person in charge? And you have also talked about setting up of a consultant. So do you need a board of directors, and who are going to be the board members? What about patient group representatives or representatives from the medical sector? So, well, when I was talking about the committee, I was talking about the medical advisory committee. And how about the financial transparency and the decision making? Can you elaborate on the idea of corporate governance? Or is it the case that as long as you have appointed someone to be the person in charge, that will do? Well, let me first explain, and I will defer to Dr. Chiu for details. We will have to refer to the existing legislation. Cap 165 is very simple. The law only requires the D of H to ensure that the hospital has sufficient equipment, manpower, and space. But in the document, you will find 19 areas with requirements on the private hospital. One of the areas is the corporate governance. We do not set out the membership of the board of directors or the advisory committee. In the future, when we have the legislation, we will make out the details of the membership of the governing board. Mr. Chin Kimpo. Well, Dr. Ki Kwok talked about an increase of 30%. I would like to get a clarification because the Commission on Insurance have recently done a survey, and in 2013 is actually 32%. Please verify the figure and supplement the information. Well, under your proposal, there is a standardization of plans and coverage. An expansion of coverage is, of course, a good thing for consumers. And when it comes to premium, the consultant said is going to be about 3,600. But there is a variance or margin of there is a margin of variation. In one of the meetings, we talked about this. The 3,600 is plus or minus 45%. If you refer to page 58, that is those between 45 to 49. The consultant said is $4,750 when it comes to premium. And there is an increase of 6% in premium. So in 2017, we're talking about $6,300. With the variation, that is an increase of 45%, we're talking about $9,124 in premium. I think your theory is very different from those of members. Well, because some members don't want to see anything about a subsidy. But currently in the public sector, there is a subsidy of 97%. And for those with high risk, if they pay $10,000 or $20,000, is not a subsidy. I don't understand why these members say things like that. Perhaps they suffering from a constipation in their brain. Of course, there needs to be risk sharing. You have to have young and healthy people in the market. If you rely solely on subsidy, it doesn't work. Well, the original proposal is $50 billion. Say, for example, a 30% discount on the first take-up, and then also 30% off when it comes to a long patronage. So you will save about $1,000. So it's very different from a save of just several $100s in tax. So that is a problem of sustainability. If you can attract healthy and young people to take our policies, of course there will be risk sharing. And healthy people will become unhealthy and young people will become old. You have generations of young people to make it sustainable. But there is well, since it's not mandatory, then there is no incentive for people to keep joining. In a radio show, Dr. Louis Shi said that, well, this proposal will not be sustainable. So I wonder whether it is indeed sustainable, the proposal itself. And that itself is a problem. I have a lot of questions to ask, but I would like to focus on this. Well, originally we had $50 billion. You didn't have to go and ask for it. And this is part and parcel to the health insurance scheme to control private sector, to enhance fees transparency, and also to subsidize the premium and the use of $50 billion. But there is no more information in this regard. How can you ensure sustainability? When it comes to subsidy, well, of course, I don't want to see people say that whenever there is subsidy, then there's a subsidy of the private sector. Well, there is a high subsidy rate in public sector. If more people can go to the private sector, then it will make available capacity in the public sector to serve more people. So don't see subsidy as something that is negative. And of course, when it comes to premium, we have to attract younger people. And we've been saying that we don't just attract high-risk people. We have to have the high-risk pool because we have to deal with this before we can make insurers accept the high-risk people. When it comes to incentive, we have to look at quality. I think Mr. Chan's question is why don't you use the $50 billion and a 30% premium discount? We've heard a lot of views that they don't want to see direct subsidy from the government. So if we use tax deduction is one of the ways, and it's not taking money directly from the $50 billion. And if we use tax deductions, perhaps you may say that at the beginning, the annual amount will be small, but it will snowball, and the amount will increase. And we have to attract healthy people. And quality is very important. There are a lot of people who are ill, but they are healthy, comparatively speaking. And because they're suffering from certain conditions, they are unable to take out policies.
So these are not the people of highest risk. So we must not discuss only the extreme cases. Some are with many illnesses and some are all healthy. Now there are many in the middle class. They have the financial ability to buy insurance, but they couldn't buy it. Now, why don't you just give them the few $100s? Now, we did propose other concepts. For instance, after purchase of cover within a certain period, one didn't make any claims, then there would be a discount. And we considered that mechanism. It would provide not a not very healthy incentive. So in traffic safety, we try to promote safety, but for health, we cannot control health. So if there's NCB and people don't go to see a doctor, that's not that good. Vincent Fan? The Liberal Party in principle supports the document. Now, private doctors and private hospitals do have the extra capacity to take care of more patients, and so it's a good thing to get people to patronize them. Now, on the regulation of private healthcare facilities, I am concerned mainly about this. Now, you make a clear distinction among hospitals, public hospitals versus private hospitals. And then there are ambulatory centers. There are more and more of them. Now, there are a group of doctors who come in partnership, and then they form what you might call an ambulatory center or whatever, and the equipment do meet the standards for regulation. But what causes concern is some clinics engage in high-risk ambulatory procedures. This is what we are most concerned about. How do you regulate them? What would you classify as ambulatory centers? And what would they be permitted to do? And when doctors incorporate, what can they do or cannot do? And then there are some companies that operate medical centers on quite a large, that are of a large scale. So we are concerned about whether these doctors are qualified, and in terms of especially clinical experience. For instance, beauty centers, they hire many lawyers. Now, are they in line with regulation? Now, of course, both public and private hospitals have ambulatory centers, and clinics have been opened that are not within hospitals. But if these facilities belong to the hospitals, even though they are not physically in the hospital, they are still within the hospitals as far as regulation is concerned. Now, Mr. Fang is concerned about these ambulatory centers in the community. There is no clear system governing them. Now, previously, this is okay because most high-risk procedures are done within hospitals. But now, as technology develops, many procedures don't have to be carried out in hospitals. And so a lot of this is so-called high-risk cosmetic procedures. Now, so they should be regulated as private healthcare facilities, taking into account their risk. Now, we need to look at the risk of the procedure, of the anesthetics, and then of the quality in respect of the patient. Now, if there is risk in any of these three aspects, whether it's a center or a clinic or part of a beauty parlor, now, if it's high risk in any of these three aspects, then they would fall under our regulation, under the proposal. Now, you mentioned that some of the services would be provided by companies. Now, we are concerned now if the right of management is under a doctor and medical procedures are under him that are of high risk and complicated. Now, that would also come under our regulation, under the proposal. Albert Chen, I did make my views known to the Secretary. I am very wary of the healthcare insurance schemes. Your ultimate product will let people make money in many ways, and those who pay the premium would be on the hook. They would find out that some of the services are not covered. Eventually, they have to pay up or prepare themselves for death. That would be the eventual choice. Now, the Mandatory Provident Fund also had a similar problem. Now, that also applies to the fee, fee adjustment, double fees, adjustable public transportation fare scheme. Now, if the bus companies accept that scheme, well, ultimately the grassroots would lose out. Now, first of all, I must praise the government that in that it tries to strike a balance. However, there are three issues to be resolved. Now, I prefer the Canadian model. That is, it's one market, one system, covering all healthcare problems, no distinction between public and private, no classification into classes. Now, many commentators have this query. Now, if people are elderly or of poor health, they would be the ones who take out the cover. The young people do not take out cover. So you are likely to lose money. Now, after the initial expenditure by the government is used up, the initial fund is used up, then you either have to raise the premium or invest more. Now, so you may be able to afford it only for a few years. Now, if you leave the doctors to join voluntarily, then there are doctors like Dr. Leung Chi-hong who are patronized by the very rich people who are of the top qualifications. They would not join. So those who join doctors who join the scheme would be regarded as of lesser capability. And then thirdly, there is the question of premium loading. Now, the doctor might find ways to levy additional charges. Now, briefly, first of all, on the Canadian system. After consultation, we find that the public is mostly against a mandatory public scheme. And secondly, is it that only the people of poor health who take out cover? I don't quite agree. Now, we have a public healthcare system, so people who are very ill, they do not depend on the VHIS and patronize the private providers. In fact, the very ill people, even the rich people, when they come under a major illness, such as if they have a stroke, they would go back to the public hospitals. So now, the purpose of our high-risk pool is not to attract those who are critically ill, but to offer a choice to the middle class, because they do wish to have the middle class do wish to have a choice. If they can afford to buy insurance, they would prefer to get better and higher quality service at private hospitals. Right now, they don't have a choice. They have to queue up at public hospitals. And on the issue of charges, now we don't have a mechanism to force the top doctors to join. However, most private hospitals do understand that the government wants to encourage the development of hospitals for the middle class. So the universities would be involved too, so the middle class can make use of these hospitals. This is where the bottleneck exists in the private sector. Now, there are some surgeries that are not critically urgent, but if the people queue up in the public hospitals, they have to wait so long that the illness becomes critical. So hopefully, with the new scheme, the middle class do not have to wait so long in the queue. Now, on the fees, some insurance companies have reached agreements with private hospitals, and so those who purchase the cover can have the surgeries done at certain hospitals, and they don't have to pay additional fees. Now, of course, there are other examples. We allow the patient, if he to choose his own doctor or hospitals, and that's over and above what's agreed with the insurance company. The insurance company will sort out with him how much more he has to pay. Now, our public healthcare system, we members agree that it's relatively efficient in providing protection for the public. The public revenue is deployed to give good protection to the public. Now, we are better than Canada, because in Canada, rich people do not have the choice. They still have to queue. Now, of course, if people want to have a choice, we shouldn't deprive them of their right. The issue is, do we have a need, or what need do we have to use public funds to support some well-to-do middle class? I don't mean the richest people, so that they have a choice for a better service. Why do we need to do that?
It's just like Class B bed, something that we've mentioned before, and it's no longer in existence. At that time, the administration said that the proposal had its merits. It can benchmark some effective products, and they could use the chance to regulate these products. Just simply go ahead with the regulation. There is no need to put in place any subsidy of the standard products. And if you use public funds to subsidize those that are better off, to give them more choices, then I would ask, what advantage does it have for those who are on the lowest stratum of society? Well, the waiting time for specialists is very long, and for examinations is even longer. Recently, there is a subsidy of examination of a rectal rectal colon examination, and even after the examination of your stool, you will have to maybe have a colonoscopy. So I think that if it's subsidy, it shouldn't really be used to just subsidize the middle class. And as Ms. Helena Wong said, it increases moral risk, and it will also increase service demand. And manpower will be drained from the public sector. And the public sector is already having a very tough time. If there is a further brain drain, the quality will deteriorate. It will suffer. I would rather that you use the money to subsidize patients to get examinations in the private sector, and in this way it will be more effective, and the service will be made available for those who are in need. We would like to keep the dual-track system. We want to keep the choice. That's why we designed this proposal. Otherwise, we will design the Singaporean approach or the Canadian approach. We would like to keep the dual-track approach that is in existence now. Through the VHIS, some patients will be shifted from the public sector. You're right, subsidy is not the main part. We enable some people to take out policies because there are people who have the money but are unable to take any policies. Please ask people in the middle class that you know, how many of them are unable to take out an insurance policy? There will be enhancement of service. And after that, yes, there is a small pressure on fee increase. The only subsidy is the tax deduction. We will have further discussions before we set the level, and it will only offset some of the pressure of premium increase as a result of quality enhancement. But in this way, we can enhance quality, and we can also enable some people to take out policies. The tax deduction is just to alleviate some of the pressure on premium increase. And in our proposal, we're talking about $4 billion or so, and it will go into the high-risk pool to deal with patients of high risk. Otherwise, we cannot make insurers to accept policies of high-risk patients. If we do not tackle high-risk pool, we can't impose a requirement to get insurers to accept high-risk customers. And yes, there is well, if we use the $50 billion, we could only subsidize people to go to the private sector. And at the same time, we have to get the financial secretary to give us money to build more hospitals, and we're talking about another $10 or $20 billion. The government will continue to support the development of public health care services. Why not outsource services? Yes, in our design, some of it goes to these outsourced services. And we are reviewing manpower supply, and there are there is the idea is that close to 2020, the supply demand of manpower will improve. We have Dr. Joseph Leung, and we have also a number of members who would like to speak for the second time. For the first round, Ms. Elizabeth Quat. A number of members have asked this. If you're unable to attract young and healthy people to join, will the scheme be unsustainable at one point? In short, for middle class, those who are younger in comparison, or those in the early middle age, they are in general healthy but maybe suffering from some conditions. The scheme will be attractive, and there are a considerable number of this group of people. You just talk to people around you. I've spoken to professionals, people who are in SMEs. The scheme is attractive to them. So we do not think that we will only attract high-risk people to join. We will be able to attract younger, not students or those who have just graduated, but younger people. So what do you mean? Is that if it succeeds in attracting younger people, healthier people who can join the scheme, then the scheme will be sustainable. Yes. A lot of people go to the public sector and not the private sector because, as you said, that the public sector is a primary service provider when it comes to secondary and tertiary care services. When it comes to major operations, people would prefer the public sector because they would feel that it will be safer. Maybe there will be better doctors. So when it comes to outpatients or minor operations, is it the case that you want to keep them in the private or the public sector? Will you talk about urgent illnesses and very serious illness? That's one end of the spectrum, and the other spectrum is minor ailment. And we're not tackling these two ends. We're talking about the bottleneck. We have devoted a lot of resources in the public sector, but with an aging population and an increasing demand, on top of that, there is a group of people who cannot take out an insurance policy. There is pressure for the public sector to give priority to those who are suffering from grave illnesses, urgent cases, and those cases that involve interdisciplinary professionals. So we see that we see non-emergency cases in A&E or non-specialist cases in the specialist queue. If we can attract some of the middle class to take out policies, well, it's not the case that we stop them from going to the public hospital once they've taken a policy. We would like the middle class to think that if it's serious illness or injury, of course they can go back to the public hospital. And if they have the choice, say for example some elective procedure, and if they choose to go to private hospitals, then it will alleviate the pressure on the public hospital because they can devote resources to people who don't have the choice, grassroots, who rely solely on the public hospitals. Mr. Chen Kimpo. Well, the major objection is that the FSB should not impose too many restrictions. In Singapore, well, without competition, And well, perhaps there will be a lot of products, and healthy people will not choose certain products. And if you want to use the $50 billion in offering discounts, then, well, for those who meet minimum requirement, there will be discounts. And as a result, there is competition, and you can attract young and healthy people to take out policies. I remember in the meeting, Secretary, you said we pointed out to you that if you went ahead, then some people who are unable to take out certain products, they were forced to go back to the public hospital. We have compiled some statistics. We see that in Hong Kong we have done a survey on 1.8 million policy holders. Those who are paying under 2,000, 27%, between 2000 2005, 13%, 2005 to 3,000, 11%. So about 80,000 people are paying a premium of under 3,000 at 2013 prices. If you do not change your strategy, hundreds of thousands or even millions of people will not be able to take out a policy anymore. Well, they cannot afford to pay the premium. And if they can't pay the premium, then they will go to the public sector. And this is contrary to the objective of your proposal. So I hope that, Secretary, you will have a detailed discussion with the sector. We will listen to the facts. We've reached a stage, just like constitutional reform, is whether to go ahead or not. Please make final adjustments to make it acceptable. We have had discussions with you over a number of years. At the beginning, we were at loggerheads and we made concessions. We think the 12 areas are 12 requirements are okay because there is no limitation on pricing. Well, if the public knows about the high premium and they accept it, there is no problem. Then why do you just make people take out policies that meet minimum requirement? You can teach the public through publicity and education. That will be effective. You have to maintain free market here. There is no insurance product that has been regulated by the government. For product, maybe you have to meet certain requirements of the, say, SFC, say, for example, disclosure, no misleading information. That itself is important. Well, I've been arguing with the PS and the Secretary for a long time. Out of the 1.5 million, half of the people are paying a low premium. So how are you going to deal with this? You're a responsible government. I hope we can exchange views and we can work out a proposal that will benefit everyone. As I said at the outset, coverage, protection, we have an idea. If members decide to veto this, because there is a certain element of subsidy, albeit a high-risk group, well, we have considered doing it voluntarily to meet the minimum requirement. We think that the standardization is the best part of the proposal. Any response from the Secretary?
No, we can get further data from Mr. Chen, and we will continue to communicate with Mr. Chen and industry. Mr. U.C. Wing. Is it Dr. Leung Ka-Lau first? I'm sorry, Mr. Chen had to leave first, so we let him speak first. Dr. Leung Ka-Lau, let me first ask a question, because there will be the subcommittee who will follow up later. Now, the Secretary said that we need a high-risk pool, otherwise we cannot make the insurance companies meet the minimum requirements and take on all patrons. Now, but under your scheme, after 1 year, for those who are under 40, for over 40, will not be covered. So someone may have failed to join in the first year, and then he becomes ill. Then the insurance companies don't take him on, don't accept him, or they increase the loading to over threefold. Now, if he's under 40, then the government will take him on. But if he's over 40, even the government will not take him on. So some people will not be able to get cover. And previously, it was asked of the government. Now, for these over 40, if you do not cover them, will you allow the market to provide some products who do not meet the minimum requirements, but yet cover certain illnesses while excluding some illnesses? So, for people after 40, over 40, will you let the market provide the product? Now, this is a novel issue because Dr. Leung is saying that for the high-risk patients, so the risk is over threefold the standard plan, and then after the period stipulated, he has not bought the cover. Well, he wouldn't be able to buy it now. No, not necessarily. Now, the insurance companies may not cover the pre-existing illnesses, but the insurance company can cover his other illnesses. Okay, so these many of these patients may not be able to buy the cover, so they will go back to the public hospital. The public hospitals are always the large safety net available. Now, on your new question, it's something new. I am not able to answer right now. I will have to think about it first. So if you not provide the support, so after the first year for people to join, will you give them an additional choice or option? Okay, I will let you answer later. I have a further follow-up question. Okay. It's what Chen Kim-po said. Why don't you let the private sector handle it? We will. Okay. On the question of those over 40, now, can you set back the age, raise the age? Because earlier you were talking about over 55. Now, well, most of us here are over 40, right? So if you leave them only 1 year to decide, that's rather harsh. So the government can it provide some data later on this? Now, many people think that public hospitals have lower cost than the private sector, but that is not a rule, as people found out in the past couple of years for certain items. Now, the Secretary can go back and get the figures from hospital authority, the endoscopy for the internal organs and intestines. Now, how do the costs of the HA compare with those of the private market? Now, this is so that people know whether the costs will increase if you try to develop the private sector more, whether the overall cost for society would be higher. Now, there's one thing about the insurance cover right now available, and that is that the payout is not enough. The surgery costs $100,000, but the insurance companies only pays only $50,000. Now, that's also in your consultation document. Now, if for some major surgeries like heart surgeries, the cost will be $200,000 to $300,000. So for that category, the cover is not enough. Now, of the questions that you raised, many of them we take on board these issues, and we go back and think about them. Now, it's very difficult to set a level that covers everything because there is a large range in terms of for the cost of surgeries. Now, some hospital schemes, now even if it's a major surgery, the amount that can be covered is still very much below that for many private hospitals. Now, we are just trying to have a reasonable level so that covers a large proportion of the surgeries. We can't cover all kinds of surgeries. Mr. Yu Si-wing, I support the VHIS. We see that there are 1.8 odd million purchasers of private insurance cover. So why don't the others buy the cover? Very often it's because the companies provide the cover, but when they retire, they lose the cover. Many of these people are in the middle class. Now, there are more people in this category now. Now, the middle class, they haven't bought the cover, so they go to the public hospitals. Now, they have some money, they like to buy cover, but it's too expensive right now. So I think the VHIS can resolve this problem for the other people outside the 1.8 odd million. Now, in 3.26, you said that you encourage more people to purchase cover so that there's a savings function being fulfilled. But you say there's a problem because some of savings can only be used for further medical cover, and the money cannot be withdrawn for other uses. So some young people are turned away. So the idea is a good one. I think the young people would like to purchase cover, but they would also like the option to take out the money for other uses and not just for renewal of cover. So that would be a good solution. Now, also on the regulatory framework, now I do agree there's a need for a regulatory framework that would raise transparency on charges and so on. Now, it's not very clear. Will it be a government framework or a public framework? Now, if it's a government framework, who will pay? And if it's a public framework, is it professional enough? On your first question, now it's one of the proposals in the first stage of consultation. Now, during consultation, different views emerged. So this time, we have not used that as part of our core proposal. So we will not focus on the savings part right now. So now on your second question, on the management framework, now it's the Department of Health, i.e. the government, who will operate it. We will step up the power for the Department of Health to regulate private healthcare facilities. Now, on the degree of professionalism, we cannot meet all demands. Now, the Department of Health will try to get specialists to help, but the regulation is through legislation for the DH to regulate. Now, if there are administrative fees, now, of course, we try to recover some costs through license fees, but we wouldn't be able to recover all the costs. So the government does have to provide some of the funds. Now, will it be made clear is that a percentage of the premium will be used for the regulation for these fees? The Permanent Secretary, our thinking is this. Now, the Commissioner on Insurance, it regulates the whole insurance market. We try to ensure that the insurance products do meet the interests of the consumers, and also there would be fairness in dealing with complaints so that the public is confident. Now, so if we do embark upon this, there would be a small group within our department. It doesn't have to be a large group. This would come under our day-to-day operations. In the second round, Dr. Kwok-Ha-Ki. Just now I didn't have time to ask this. First question for the administration. Now, your objective is to push people out to the private sector. Is that so? Secondly, we use the hospitals, but it's a high cost and inefficient approach. If the government wants to reduce its burden for medical expenses, it should engage in preventive medicine for the entire Hong Kong population. For, say, type B hepatitis patients, they should be provided with regular ultrasonic checks, or if there's someone who has colon cancer in the history of his family, then the government should provide tests for them. Now, paying for insurance is not a wise approach. There are 2.79 people buying insurance cover in Hong Kong, and most of them, a lot of them, are buying medical insurance. Now, you haven't done anything, but they already buy insurance on their own accord for their own needs. Now, in 2003 to 2004, at the time, medical expenses were 50% of total, 60% of total government expenditure. And now, in 2014, the percentage is 40. The government share is 49%, and the public sector's private sector share is 51%. Now, you try to attract the young people. Now, those who want to purchase cover already purchased the cover. For those who are young people who just graduated, they haven't the financial means to purchase cover. Now, what is the wage increase? Over for the past decade, university graduates have seen a salary increase of less than 10%.
So how many more people would you like to push from the public to the private sector? Why don't you devote more resources on primary care? Don't waste your money like that. Use your money to help people who are in need. Those in the high-risk pool, those who are over 65, and some people said that when they retire, they should be very happy. I don't know what they're happy about. without the additional premium is $9,000. So you have to pay about $20,000 before you can join the pool. How many people will be able to afford that? First, let me reiterate again that we're not pushing people to the private sector. It's their choice. We've made it very clear, as the name suggests, that it's voluntary. If there are people who do not choose to do so, then they will not be pushed to do so. And I agree that when it comes to primary care, especially primary care is very important, especially prevention. When it comes to health census or survey, we are met with a lot of resistance because public money is used and the effect is not instant. And we have to expand capacity in both private and public sectors. In the policy address last year, a survey of common cancer found in Hong Kong will be done. It's announced in the policy address. We're not pushing people to stay in hospital. We're talking about inpatient procedures. It's just that if they have the choice with the insurance coverage, they don't have to wait in the public sector. They can choose to go to a private hospital. So for people who are in the same queue in the public sector and those who cannot choose to go to private, then they don't have to wait as long. So why is the scheme on admission only and not community health? Because for primary health care in Hong Kong is paid normally by people make by members of the public with their out-of-pocket payment, and we want to put in place a safety net. It's not my decision. The fact is, over 70% of primary care are provided by the private market. And it's not the case that we do not promote primary health care. It's not what this document is about. Well, there is huge pressure on the hospital authority, and grassroots don't have the choice, and they have to rely on the public service. And as a result, service suffers and the waiting time suffers as well. And the situation will be worse in the future. We have to put in place a mechanism to maintain sustainability on the secondary health care. It's not that we don't attach importance on primary health care. It's just that it's not mentioned fully in the document. PS would like to supplement. Let me supplement. I hope I will be able to help Mr. Kwok. Dr. Kwok, you talk about primary care. That is, those who are otherwise healthy. We are already doing something. And for people who have fallen ill, from our experience, from research of overseas jurisdictions, that if regulation of insurance product is good, say for example standardization, it will help primary care. Because people won't listen to you if you ask them to quit smoking or to exercise. But when there is subsidy or with proper premium arrangements, they will take the first step to take out an insurance policy. And then we can work with insurers. In overseas countries, insurers put in place some health management schemes, which is beneficial to public health. When it comes to people who have retired. Well, when people are working, some of them are covered by group policy. When they retire, when they reach 60 or 65, I am sure you understand that most of them will be suffering from one condition or another, say hypertension. Well, when a group policy is taken, an option should be given to the employer at an additional premium of 1 or 2%, so that employees, when they retire, can switch to an individual health insurance, as if they have always been taking out a policy. There is no need for re-underwriting. Say, for example, when a person is suffering from some ailment or hypertension, when the conversion is taken, then after the person retires, then he can switch from a group policy to an individual policy. And that's something that's already been done by some insurers. Normally, when a person retires, because of health reasons, the person will find it difficult to take out a policy, or the person will have to add a lot of loading. Dr. Kwok? Well, if there are no other people, since we still have some time, we talk about if we are talking about a principle or a debate. Well, we have another chance. Of course, if you can't agree on principle, well, the remaining 10 minutes will not be long enough. We still have a subcommittee. Let me ask a third round because we have time. Yes, it's just that I want to make it clear to you. This is not the last meeting. And the consultation period ends in March. So we have plenty of time to talk about this. When it comes to detailed discussions on the VHIS, we can do it in the subcommittee. We'll first have a public hearing and then we will discuss this item. The panel can hold a special meeting to discuss the regulation of private healthcare facilities and hold a public hearing. Dr. Kwok, you may continue. It's a question for the PS. We still have plenty of time. Just now you said that, well, when someone reaches a retirement age at 60 or 65, it's very important. In 2012, we're talking about $8,600 in premium for someone who has retired. And if the person cannot get into the high-risk pool, then there is no subsidy whatsoever. But even when you are in the pool, you will have to pay 200% of premium. That is $28,000 to $30,000 a year. My question was clear. In your calculation, how many people in Hong Kong are in a position to afford close to $30,000 premium after they have retired? Please explain to us as well, PS. Is it the case that if you take out policy when you're 65 and above, then it will cost you $8,000 to $9,000? And if there is a group policy, say by the company, and if there is switching, we're talking about a different premium. Is that right? And when a person reaches 65, and the person takes out a policy for the first time, is it a target group of your VHIS? Or you just are thinking that for these people they can continue to use the public sector? If an insurance is taken out by the employer, and when the person retires, what happens now is, say I reach 65, I leave the company, then I don't have any insurance coverage. And, well, I will have to take out an individual policy. And as you know that when you're 65, you have, you may have hypertension or diabetes. Then the insurer will have to underwrite you, and you're talking about a higher premium than other people. Well, what we're talking about is that if you're covered by group insurance, say one taken out by the company, then if you switch, then the insurer will treat you as you have already been covered. Say if you're 64, then you're paying you will have to pay $6,900 in premium, because you're treated as if you have always been covered by a policy. And so there is no jump in premium for like someone who has just taken out the insurance for the first time. So if you are in this group, then you don't have to worry that if you're suffering from, say, hypertension, you will have to pay a lot more in premium if you want to take out a policy. For the high risk group, 200 or 300%, yes. If you're 65, you will have to pay premium of about $30,000. Well, it's not compulsory. It's voluntary. The pressure in the public sector is on the routine cases, hip replacement, cataract, prostate, etc. And we hope that younger people will take out insurance scheme. If you're just in your 20s or 30s, you only have to pay $1,000 or $2,000 a year. And once you've taken out a policy, and in the future, if you develop other conditions, according to the minimum requirement, you will still be covered. And there won't be a huge jump in premium. So when you're, say, 40s or 50s, you're only paying $4,000 in premium. We have a sound of a public system, and we want to devote it to dealing with complicated cases and to serve people who are really in need, say elderly people. In the U.S., there is no such thing as the public sector. Even if you're in your 90s, you have to take out an insurance. So those in their 20s will have to share the risk with those who are in their 90s. It may not be $3,600. It may be an increase of 45%. In the U.S., well, we're talking about MRT, diagnostic imaging. There is no deductibles, no sharing. That's why it's 45% higher in the U.S. In OECD, is similar. The sharing is about 30%. So if the doctor asks the patient to have a diagnostic imaging done, then they'll have to pay about 30% more. And in OECD, it's about $3,600. Elizabeth Watt. I've recently heard from people from the insurance sector that they resist this proposal. You need the participation of the insurance sector.
How confident is the Secretary of convincing the insurance sector to join? Now, I think the insurance sector is against it for a simple reason. Now, on page 13, now you can see, as Mr. Chen Kim-po said, that the 36% expense loading. Now, actually, that's fallen to about 32%. That's the expense loading. That is non-claims portion. But for most other places, it's under 20%, the expense loading. And as the Secretary explained, Hong Kong is special. We have a good public health care system. So people buy low-cost insurance, $2,000. People don't know what is covered. Now, when there is a surgery, now the surgery cost is $40,000-$50,000. So that's why many people end up in the public healthcare sector. If you have been to the hospital 10 times recently, 5 times would be to the public hospital. Of course, I am saying that for the other 50% of the cases, it's not necessarily to the public sector. So if it's $300 per day for a hospital cost, now if you pay the insurance and yet you have to you usually use up the cover, so and you have to pay out of pocket, so people go back to the public hospital. Now we are trying to make it improve the things so that people can have can see the charges that are all comparable, and so this is to protect the consumer, but you have to take out the cover every year now. So you also need high transparency. So all this requires good market practice to help to protect the consumer, and the expense loading. We try to lower that from 35% to an internationally acceptable level. So that's why the insurance sector has some resentment against it. But Mr. Chan Kim Paul said the trade also has some proposals, so we are continuing to talk to them. I hope the Secretary tell me whether he's confident of convincing the insurance sector to join. Well, if you want a simple answer, I'm cautiously optimistic, but I'm not 100% confident. If the Secretary cannot convince the insurance sector, do you have a plan B? It depends on the views of the public and of LegCo and of other stakeholders, because ultimately it has to be through legislation that goes through LegCo. So no piece of legislation can be 100% agreed. So we hope to have a high enough level of consensus so that legislation can achieve our objective. To simply answer your question, now we've been through several years of discussion, and in the past year or so, the insurance policies issued by insurance companies are similar to what we are proposing, and the charges have been similar. So if you go on the internet, you see that the latest policies are very similar to ours. There are several minutes left. I will answer the questions. I have some questions myself. Now you have two consultation documents. One is on health insurance and the other is on regulation of private healthcare facilities. Now there is a hypothetical question. Now if the scheme comes out and people don't join, will you still embark on the regulation of private healthcare facilities, or are the two bundled together? The answer is no, because on the regulation of private healthcare facilities is also achieves its own purposes, not just the VHIS. So I think it's about time. As I said, the issues can be discussed in the subcommittees and other committees. So we thank you for attending. The Secretariat will notify you of the time for next meeting.